the pleasure of inviting Dr. CHOU for the talk on choroidal melanoma prognostication without cytogenetics.
Hello everyone, I'm Honda from Taiwan. It's a pleasure to be here and thank you for the kind invitation. And we had a great time in New Delhi as well as Taj Mahal. So thank you so much for Prof arranging everything. Oh, I need to kick my own slides. So it's my pleasure today to talk about choroidal melanoma prognostication without genetics. So 50% is a figure that we commonly see in uveal melanoma papers. However, for any patient without a prognostication, it is actually 100%. 100% of the patient, they will always be concerned and worried which half they belong to. The power of prognostication in uveal melanoma, we could possibly offer half of the patients with a good prognosis and another half with bad prognosis, unfortunately, but that they can get on with life planning after passing through the 5 stages of grief and work hard on getting early detection of metastasis as well as clinical trial opportunities. The prognostication used to be based on clinical or histopathological features. However, in the recent 2 decades, the genetic features, especially chromosome 3 loss, provided a better stratification between the good and the bad prognosis, and it has become the standard of care in many regions. However, in our part of the world, there are still many barriers. It is mainly due to the rarity of uveal melanomas in Asians. It has made the cost of each genetic test exams to be much higher, and it has made the setting up and the validation of the genetic test in a new laboratory much more challenging. Therefore, we ask ourselves, can we possibly find a surrogate for genetic tests without actually doing a genetic testing? There are possible predictors of chromosome 3 loss listed here, but the most important association is BAP1 mutation. BAP1 is a tumor suppressor gene sitting on chromosome 3p that encodes BAP1 protein, and the BAP1 protein expression can be easily accessed by nuclear BAP1 immunohistochemical staining, which is a cheap, easy, and widely adopted technique in almost all pathology laboratory around the world. In our recent project, we aim at using all these features to predict chromosome 3 loss without actually doing genetic tests. We gather up around 2,500 cases in the Liverpool cohort with a mean follow-up of 4 years. Half of them had a chromosome 3 status, a quarter had nuclear BAP1 stain. We constructed a chromosome 3 loss prediction model using 11 predictors listed here. We have a very good AUC curve. The nuclear BAP1 stain contributed to over half of the prediction power. We want to get rid of all the genetic test requirements, so we deleted our chromosome 8q gain and came up with a simplified model with 10 predictors. And you can see that the area under the curve is still good at 88%, and the sensitivity and specificity is around 80%. We further want to look at the actual prognostication value of the predicted chromosome 3 status. The LUMPO3 algorithm was constructed using over 4,000 cases in the UK. It has been externally validated, is available online. The prognostication predictors included clinical, histopathological, and genetic features. Here, we replaced the genetic features with the BAP1 predicted chromosome 3 loss model, and we call this the BAP1-based LUMPO. We compare the performance of this LUMPO against the benchmark, which is the genetic-based LUMPO. As a result, we can see this calibration graph. The metastasis risk according to BAP1-based LUMPO is mapped against the benchmark, the genetic-based LUMPO. So if they were of exact match, expect to see a diagonal line like a red line here. But as you can see, the dots scattered around the place, and the exact match were only 38%. So that is not very ideal. But if you give them a bit of room for error, you can see that actually 87% of the prediction according to the BAP1-based LUMPO falls within 10% from the reference. So that is actually not bad. We further look at the surveillance planning. In Liverpool practice, if you have a predicted metastasis risk over 10%, then you will be put into the high-risk group and require a regular liver surveillance. So we can draw the 10% threshold on the graph and come up with all the different quadrants. So actually, whether you use BAP1-based LUMPO or genetic-based LUMPO, the surveillance decision will be identical in 94% of the patients. 4% of patients, they fall within the over-surveillance quadrant. That means they have actually the lower risk, but will be put into the high-risk group based on the BAP1-based LUMPO. So these patients are still within the safety net. The more concerning patient is not a lot, only 2%. They will fall into the under-surveillance category, meaning they have high risk but will be put into the low-risk group based on BAP1-based LUMPO algorithm. So in conclusion, we constructed a model that accurately predicted chromosome 3 loss without needing the actual genetic testing. So the BAP1-based LUMPO, the metastasis risk prediction, 87% fall within 10% from the benchmark prediction, and 94% the surveillance decisions will be identical to the genetic-based LUMPO. So back to our initial question, yes, it is possible to predict chromosome 3 loss without genetic testing. What we really need is BAP1 immunohistochemistry staining, and this is a simple and cheap and a practical way to improve survival prognostication, especially in this part of the world. So I'd like to thank my mentors and my colleagues in the Liverpool Ocular Oncology Research Group, and thank you so much for your attention.